Today is World Asthma Day. We are privileged as the respiratory and diseases units of the Kenyatta National Hospital to be hosting this webinar, which is meant to celebrate World Asthma Day. The theme, as you can see on your screen, is Asthma Care for All. And today we have three distinguished speakers from the unit. The first one will be Dr. Nyale, then followed by Dr. Moyaye. Then the lady will be finished. Last but not least. So we'll start off with Dr. Nyale. I think they will take maybe 20 minutes each, but we have an hour of talks and then we'll have questions afterwards. So Dr. Nyale is if I may introduce him, he's an eminent pulmonologist working in the Kenyatta National Hospital and elsewhere in this town. He's very passionate about asthma, so you may safely call him an asthmatologist, if there's such a term. And he'll start off by tackling the topic, what is asthma? He's been very busy the whole day. I hope he has a voice to give us a nice presentation. Welcome, Dr. Nyale. Dr. Nyale. Hello. Yeah, I've even introduced you. I'm waiting for you now to load your slides. Don't know. So, but we have introduced you. Hello. Oh, okay.
Sorry, I was having a technical challenge. I couldn't hear you, but now that I can hear you, let me load my slides and start. Thank you very much for the introduction, which I didn't hear. Let me share my slides. So I'll take about screen share options.
20 minutes.
20 minutes to be able to talk. We can start sharing. Where's share now? Share screen, okay. So this is in commemoration. I think people can see my slides now. Are you able to see?
Yes, yes.
Okay. So my talk is on what is asthma and correcting misconceptions that have existed with asthma. This is a question that today we were asked, and one journalist from Citizen actually asked that question. I hope she's listening to this talk. And if you have any questions, you can write them in the question tab. My name is Dr. Nyale. I'm a consultant physician and pulmonologist practicing at the Kenyatta National Hospital. And I'll take you 20 minutes on this. So asthma is basically governed by the world body that looks at standardizing worldwide treatments for asthma. And that's a global initiative for asthma, which is GINA. Every year it gives an update. I've put the 2020 because that's when the diagnosis of asthma really changed a lot. It hasn't changed since then, and we've remained with this definition of asthma. We actually say asthma is a heterogeneous disease. Heterogeneity means it's not one disease, but a mixture of diseases or presentations that fit into one kind of picture that we call asthma. But it's majorly characterized by inflammation. And this inflammation is chronic in nature. And we've even seen that even when people don't have exacerbations or don't have symptoms, if you measure their airway inflammation using fraction expired of nitrogen, it's higher in asthmatic patients as opposed to people without asthma. but it's defined by symptoms. And these symptoms are the ones that people know. That is wheezing. Wheezing is producing a whistling sound when you breathe. The whee, 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 or shortness of breath, or feeling tight in the chest. Now, feeling tight in the chest or pain in the chest, it can take different shades. I'm seeing Mwalimu has raised his hand. Is it that you can't hear me? Are you able to hear me clearly? Muya Mwalimu, you've raised your hand, so I'm not sure. Chair, what should we do?
Just proceed, Doc. Just proceed.
Okay, thank you. You're able to hear clearly, yeah? I thought maybe he's not hearing.
Yes, we can hear clearly.
Chest tightness and cough. Those are the things that define asthma. Now, although these symptoms are there, people do not have all the symptoms. They can have one. So you can have asthma with only wheeze, or asthma with only chest tightness, or only cough. So you can only have cough sometimes, and there's a kind of asthma we call cough variant asthma, where people only cough, and they have asthma and they've never always gotten short of breath. The most important thing is that these symptoms vary over time. That means they change, and they change in their intensity, and they also change on how they present all the time. So that's called varying. So they can wax and wane even without treatment. And if you measure, then you'll see something called airway airflow limitation or obstruction when you do the lung function measurement. That is what asthma is. So there are a few basic things that you should know about asthma. Is that it's a chronic condition that affects the airways. It causes recurrent episodes of difficulty in breathing. It can occur in any age. It causes substantial burden and pain to patients, but it's not contagious, so don't confuse it with COVID or TB. It can potentially be dangerous and even can kill if not well managed, but it can easily be effectively controlled because you cannot completely eradicate it. These are the four basic things. We've talked about them. Cough, the four basic symptoms: cough, chest tightness, shortness of breath, and wheezing, which is the noisy breathing. They don't all have to be there for you to define asthma. So when you have a patient, basically, if you're looking to diagnose asthma, is a patient has respiratory symptoms, then you'll take a detailed history and you basically look at the four main symptoms we've talked about. And what you want to establish is their variation. Do they change day to day, day and night, or seasonally? Are there precipitating factors, things that bring on these symptoms, such as environmental allergens, house dust mites, animal danders, grass and pollens? And you see, these are things you find in an environment. And the question is, does a healthy environment, a clean environment, enhance asthma care? And the answer is yes. Okay. Sometimes you can have non-irritant precipitants or irritants to the airway, such as smoke, dust, fumes, and certain chemicals. Cold weather is also there. And then there are some drugs like aspirin and beta blocker, and even exercise sometimes can induce asthma. Now, exercise is with a rider, because there are some people who, about a third of the asthma patients, have something we call exercise-induced asthma. So they need extra management because their exercise can worsen their breathing. But for 2/3 of the other asthmatic patients, don't have that condition. But in general, exercise improves lung capacity and lung well-being. So we encourage people to exercise. Also note when the initial event started, that they're in childhood or adulthood, and note the exposures. And also note if there are other things that worsen these symptoms, such as upper respiratory tract infections, sinusitis, or hyperacidity. So once you've noted that, if they have that, then those are people who go beyond screening. You now go and test them for asthma. And the test to do is the spirometry. That's the world standard, which we are able to do in Kenyatta. And the Ministry of Health has made all efforts to make sure there's spirometers in the 47 counties. So now all counties are able to actually do spirometers and diagnose asthma properly. And once it's diagnosed, then it should be treated as appropriate. I'll not go into the management right now, because today's talk is about misconception. So I'll go about the misconceptions that we have in Kenya about asthma, And you can also suggest some, because these are the ones that basically I came across. So the first misconception is that, just a minute, I need to move this away. If I don't have a family history, then it can't be asthma. And as a matter of fact, this is wrong, okay? Although if you look at it biblically, all of us came from Adam and Eve, okay? And yet not all of us have asthma. That tells you that along the way, our genes have changed. And asthma is a disease of two parts, that you have the genetic predisposition and then the environmental interaction with the triggers that precipitates the symptoms, okay? So yes, you might not have a family history, but you might still suffer asthma. And we looked at this actually in our study at Kenyatta. Okay, this is one of the studies we did at Kenyatta with the African Severe Asthma Project that covered Kenya, Uganda, and Ethiopia. And basically, if you look at the numbers at KNH, we recruited about 431 patients with severe asthma. And we actually were able to show that only 53.1% of the adults coming with severe asthma had a family history. That means a whole whooping 47% did not have a family history. So the lack of a family history does not indicate that you cannot have asthma. Another myth is that I don't wheeze. So if I don't wheeze, it can't be asthma, okay? The truth is that wheezing is a common symptom of asthma. And it's caused by air rushing out through airways that have narrowed so that you produce a whistling sound, and that's what the wheeze is. When we looked at our patients in Kenyatta, again, I don't know why it's stuck, okay? You can see that wheeze in these severe asthmatics was only present in 43.4% of the asthma patients. So there are people who can have even severe asthma without a wheeze. What would be some of the reasons why people would not have a wheeze? Okay? And please note, when you don't have a wheeze, it doesn't mean your asthma is inactive. Sometimes people can't hear it, but when you put a stethoscope, you can hear. So the stethoscope can hear sometimes what the ear can't hear. When people have very severe asthma, there's very little air movement. If the air movement is so little in and out of the lung, it might not produce the whistling sound, okay? So there will be no wheeze, okay? And please note, even between the flares, there's still inflammation in asthmatic airway. So you not having a wheeze does not say that that is not asthma. The other thing is that if you get an asthma diagnosis, then it means you're an invalid. You cannot exercise, you cannot play, you cannot do sports, you cannot do heavy work. And we see this a lot, okay? Even workers, once they say, oh, I have asthma, so I should not be, you should write for me a doctor's letter to say that I can't do heavy work. The truth is that exercise, yes, can be a trigger in a few patients, as we say, 30% of the patients. But if asthma is well controlled, okay, that should not occur. So it is, if the asthma is uncontrolled, that is when exercise and exertion worsens the situation. But once the doctor has treated it and it's well controlled, that should not be. And the fact is that exercise improves lung function and general well-being. So all asthmatics should be able to exercise. Also, as you exercise, you know, it improves weight loss. Again, we find it is easier to control asthma in people who are leaner than those who are obese. So well-controlled asthma means less twitchy airways and no asthmatic attacks, even when you exercise. And even for those who have exercise-induced asthma, those are the ones that we give a reliever, like Ventolin or salbutamol, half an hour to a quarter an hour before the exercise, so that we prevent them precipitating an asthmatic attack during their exercise. Another myth is that asthma is a childhood disease in ugonjwa ya utoto. And many people use that. Yes, a lot of literature around the world shows that most of the asthmatic symptoms show up in childhood. That is especially in people who have atopic asthma, and these ones will usually have a family history, okay? As we said, it's one of the genetic traits that you can inherit. I know people have a problem, and I see this a lot when I talk to people with asthma, and I tell them it could have been inherited. And all of a sudden, they are looking at their parents and wondering, you gave me a disease. You only want to inherit money, but you don't want to inherit a disease. That is not fair. If you take it, you take the whole package. So you remember, you are the child of your father. So whatever he has, or your child and your father and mother. So if they have also disease traits, yes, you have a chance of inheriting them. Now, the good part is that the chance is lower. If your father and mother have it, it's probably a quarter of the siblings will be affected. So it's quite a low penetrance for this genotype to show. But this genotype does not give you asthma. It gives you the predisposition for you to present with asthma symptoms. What it says is that you have inherited a gene that says, if I am exposed to dust or if I'm exposed to perfume, I will react more than is normal. Now, we looked at it in our adults coming with severe asthma, and we were actually astounded because we found that 65% of the adults presenting in Kenyatta with with asthma, severe asthma, did not have asthma symptoms in childhood. Whether this is memory loss or they could not remember and they didn't have their mother to ask, we didn't know. But it means that it can occur in adulthood, even when it wasn't there in childhood. And the other explanation for this was that most of the adults, probably they are being exposed to quite a number of things at their workplace, and those are causing new asthma symptoms. So there has also been a notion that most of the children get asthma, but as they grow big, the airways also grow, and then they outgrow asthma. The truth is that if you look even at the people who had asthma, and you look at those who don't have asthma, yes, the symptoms will lessen, but the inflammation is still going to be there in those genetically predisposed to have asthma. They might not wheeze because the airways have gotten bigger and they'll need a bigger dose of a trigger for them to present with symptoms. But we know quite a number of them, by the time they get to 40 years, the asthma symptoms come back, okay? So many adults can present, and we think the workplace is probably people get exposed to new allergens or chemicals, and they can lead to new asthma developing in adults. The genetic tendency to have overactive airways remains with you for the rest of your life once you have it. So even the children when they're young, yes, the airways are small, so a dose of an allergen will make the airways contract and produce a wheeze and produce symptoms of asthma. As they grow, the airways becomes bigger. The bigger pipes take a bigger dose for them to narrow and present with wheezing. It doesn't mean the genetic predisposition went away. And this, we've proved it in our studies as well. Now, another myth that needs to be shattered is what people think that inhalers are addictive. Some think they're dangerous. And over time, you'll always require a higher dose. The truth of the matter is that inhalers cause no physical or mental addiction. Science has proven this beyond reasonable doubt. And we've looked at it. If you stop this and you change to another inhaler with a different medicine, they don't crave for the old one. So they're not addicted to the medication, okay? The fact is that there are few people who make one mistake. They rely on relievers. Relievers are inhalers that you use only to relieve or abort an attack, but they don't control the main problem in asthma, which is airway inflammation. Now, when you do that, you find that the inflammation continues and you keep on having more inflammation, which is not controlled. So you keep on needing a higher dose of the reliever medication. But if you use a controller medication, the opposite happens. Inflammation reduces, and actually the dose of the medication gets reduced over time. So please note, the chronic nature of asthma requires that you have a specific routine of long-term controller medication. And we teach this in our asthma patients, even in Kenya, that you've got two kinds of medicine: a controller medication that must be taken daily, so that the inflammation in the airway is controlled and you don't get these attacks regularly. And then you have a reliever. That reliever is that if you get an overdose of the allergen, you are able to help yourself without necessarily running to a hospital. Okay? The other thing that you have to note is that you have to avoid triggers, because if we give you medication and you increase your exposure to allergens, then it means we need to also increase medication to cope with the new high-level inflammation being coped by the higher dose of the triggers. And there are people who keep on doing that. That today we give you medication at a low dose, you find, these triggers that before were causing me problems are not causing a problem now. You now start becoming more careless and exposing yourself to more things. And when you come, you have more symptoms, we have to increase medicine to try and match up to the inflammation that you've created, because you are getting unrestricted exposure to allergens. That is not the best way to deal with asthma. And avoiding the triggers and lowering your threshold of triggers basically reduces inflammation, allowing for lower doses of medication to be used on you. And remember, the higher the medication, the higher the risk of side effects. And one of the targets we try to get is lower medication so that we get less side effects. Now, if you do not treat it well, inflammation, which is actually an equivalent of a small burn, eventually it will cause permanent damage in the lung, and which is unreversible. So it's important that as early as possible, you get the best control you can for your asthma. Then another myth that also exists is that asthma is not treatable, controllable, and shortens lifespan. The truth about it is that up to 90% of the patients with asthma lead a normal life with few or no attacks, and when treated appropriately with inhaler medication, they actually achieve their full potential. In fact, we know that asthma patients don't have a shorter lifetime compared to their colleagues. The fact also is that 10%, about 10 people die of asthma worldwide. Now you can imagine a whole global population of 7 billion. It means if asthma is well controlled, asthma is not a common cause of death. The risk of death is also very lowered when asthma is well controlled, and it actually mirrors the general population. Life expectancy of asthmatic is as good as that of the general population. But it starts with you getting a correct diagnosis and a personalized treatment plan. That's the first step of good asthma control. And that's why we say today, everybody who has anything that suggests asthma should be screened and tested. And if it's found to have asthma, then they should get a good treatment. Note, it is cheaper to control asthma than to treat asthmatic attacks. Because the moment people get severe asthmatic attacks, then there are other hidden costs, including you going to the hospital, getting admitted, getting nebulized, being given oxygen and all other things that you can avoid if you control asthma well. Okay? Apart from that, the other costs I call non-economic costs, but they cost you a lot. They cost you pain, the cost of pain or cost of happiness when you miss it. And the fear that you get when you are not able to breathe, it's not worth it, not controlling your asthma. The good part is that most asthma attacks don't come like rain, they just fall out of the sky. They come slowly. And if you note, you'll find that this has been building up over 3 to 4 days before now you get to a life-threatening stage. So you have a chance where you can be able to intervene. We know also that medications are costly, but government and access programs from pharmaceutical companies are helping mitigate this. So you have no excuse not to get good medication. Then there's also the other thing that people think oral medication and more so injections is better than inhaled medication. And most of the patients, when they come to the clinic, the first thing they ask, can I get an injection? That's very false. Oral medication or injectable medication is not superior to inhaled medication. Just think about it. The moment you swallow a tablet, what you are saying is that it has to go through the tongue or through the stomach. A bit of it will be digested. About a half of it will go into the feces, no absorption. The other half will be absorbed. That is absorbed is circulated around the body, in blood. Some ends up in the liver, some ends up in the kidney, it's taken out by the kidney in urine, and then some end up in the leg, some ends up in the head, others end up in the heart, others end up in the muscle, and then about 5% of the dose is what reaches the lung. So you have to increase the dose many times for you to get an adequate dose in the lung for you to have a good effect. On the other hand, inhaled medication goes directly to the lung, okay? And that is where it's needed. That's why inhaled medication, if you note, it's measured in micrograms. That means 1/1,000 of the oral medication. A good example is looking at your prednisolone tablet. That small prednisolone tablet is 4 milligrams. That's equal to 4,000 micrograms. The inhaler that you are using, okay, of inhaled corticosteroid has 1,000 or 2,000 micrograms. So it means that one tablet of prednisolone is being divided 50 times. And that's what you are being given, 1/50 of the prednisolone tablet when you use inhaler medication. What does this mean? Is that the medication is less side effects, and yet it's more effective because it's going to the right place. So inhaler medication is superior to oral and injectable medication when you come to asthma treatment. Then there's this completely unfounded, and sometimes I know people want to believe we're a very religious country, and that's why Shakahola has happened, is that asthma is due to evil spirits that cause strangulation of the patients. I mean, for sure, this is completely false. I know I've seen most of the asthma patients, I see most of them have been prayed for. I have no problem with prayers. Prayers work. They also help the doctor to make the good diagnosis. And please note, the truth is that there's a scientific basis for asthma, and it's inflammation, and it can easily be treated. And what I tell my patients is that the doctor has been chosen by God. God has enabled him to have a good brain, to go through medical school, to get knowledge, to help his people. So he's an agent being sent by God to help you. He is not an evil spirit. And please use him so that he can be able to manage your asthma well. And please note, things that we create, including stress, fear, can trigger asthma in these patients. So let's not scare them. Let's give them facts. And we know that misconception and all these things can only be cleared by proper education. So as healthcare workers, we should give this proper advice and education to our patients. Finally, there are those who say asthma can completely be treated. And I'm addressing this to doctors in Nairobi and patients. Because once on Mombasa Road and also on Limuru Road, there was a billboard by one of the herbalists that he can completely treat asthma at one go. This is completely false. We know that asthma is a disease of two parts, that you have the genetic predisposition, which you can't change. But on the other hand, you have the environmental exposures that are under control, and those ones you can control. The truth is that asthma can be controlled, and easily so in 90% of the patients. It can be easily controlled, but you'll always remain at risk. And that's why we give you prolonged medication and prolonged inhaler therapy. And what we do is that we try and bring the inhaler medication to the lowest dose that you require to keep your asthma in check. There are even studies that we've looked at of using intermittent treatment to see if we can control your asthma, okay? And it's one of the things we do when my asthma is very mild. There are those people who get only asthma during the rainy season, and we give them inhalers at that time, okay? So the lowest medication might be inhalers once in a while, but for some, like we see in Kenyatta, is inhalers every day, sometimes twice a day, okay? Remember, you can also further control it by lowering the allergen or the triggers that the person is allergic to, and adhering to your medication is the best strategy of keeping your asthma under control. I think I'll end it there. I hope I've addressed most of the misconception. If you have others, we can address them in the question and answer session. Thank you very much. And I think I'll hand it over back to the chair so that he can invite the next speaker. Thank you very much.
Kenyale, an excellent presentation. And for keeping time, we'll now ask have the next presentation. I think we'll keep the questions until we have had the 3 sessions. So the next presentation will be the asthma from the patient perspective. And this will be done by another passionate clinician from our unit, Mr. James Moyai. I hope he is logged in.
James has had an issue. I think Kagema might give his talk. He's had an issue. He's had an emergency, so he was not able to log in.
Okay. So Kagema, are you there?
I am.
Okay. So you'll give 2 talks, or you combine it into one. All right, then the floor is yours. Now that Joan Kagima, she comes from nursing. All the people who have spoken are very passionate, but I think nobody can beat Kagima in passion. I wish we had that famous passionometer. You will agree with me that that's the case once she's given a presentation. So I think she's loaded her slide. We'll let her present. So you have maybe 20, 30 minutes, and then we'll have a discussion.
Okay, thank you. Can you hear me?
Yes, loud and clear.
Okay.
You can put it on PowerPoint.
Okay. Good evening, everyone. My name is Kagema. I'm a respiratory nurse. I want to talk about the methods of assessing asthma. So tools for assessing asthma is peak flow, spirometry, clinical symptoms, history and allergy, blood tests, ACT, which is asthma control test, and asthma care plan. Then we have another one called FINO, a fractional exhaled nitrous oxide. The 4 components of asthma management. One, we talk about the objective measures of lung function to both assess and monitor each patient's asthma. The second one is environmental control, efforts to reduce or eliminate exposure to allergens and irritants, often called asthma triggers, that induce the airway inflammation and precipitate acute asthma episodes. We have the pharmacological therapy to prevent and reverse and control airway inflammation and obstruction. Number 4 is about patient education, where I come in to help patients prepare and follow their daily management plan and the action plan for dealing with symptoms. So every time a patient is seen in the health service for anything to do with asthma, 2 methods need to be applied to assess the patient. One is clinical evaluation and lung function testing. So what is clinical evaluation? Is the usual frequency and severity of the clinical symptoms reported by the patient over the specified period being assessed at initial and annual evaluations, which is equals to over the previous 12 months when you are being followed up. At follow-up visit, which is equals to since the last consultation, has the patient had any triggers? Has the patient had an attack? Has the patient not failed to go to work just because he had an issue? So clinical symptoms are primarily those of the chest, and especially with attacks of breathlessness or chest tightness, but can also include other symptoms such as cough, as Dr. Nyali had said. So clinical evaluation at initial visit, we talk about severity of symptoms. We talk about mild. We need about the step 1, the symptoms disappear for long periods and occur less than twice a month with no exacerbation risk factor. Step 2 is symptoms may be 0 to 1 per week with a risk of severe exacerbations. We have the moderate, which is step 3 for patients with more than 1 exacerbation in the last 1 year. And we have the severe, step 4 and 5 patients who have asthma not controlled on low dose of ICS lumbar, despite good compliance and inhaler technique. That table is about the classification of asthma by severity of disease before treatment. Dr. Nyale has really talked about the issues of the symptoms and the characteristics. And when you go through that table, you talk about the characteristics like the frequency of the exacerbation. How often had the patient been having? Is it twice in a week or is it within an hour? And we go to moderate and severity. As we continue going down, that is how we assess the patient with the action care plan and action control and asthma control plan. So we come to lung function testing. We have several of what we do. We have types of peak flow meters as they are shown. This is how we do the peak flow as per that young man who is doing peak flow. So the peak flow, the peak expiratory flow rate use, it evaluates airway obstruction, monitors treatments, helps in diagnosis, post-SABA and post-exercise, and internal variability and all steroid trial. Measurement of peak expiratory flow rate, the PEF, is a practical, reliable, and cheap tool to measure a patient's PEF, which is very good in the health centers and the level 3, level 2, and around level 4 hospitals. PEF is given directly in liters per minute. PEF is correlated with 1 second forced expiratory volume 1 and repeated very easily. So PEF measurement is the main tool for diagnosis of asthma and follow-up patients where you don't have spirometry. And that is the table of the predicted values that we look into the values of men and the values of women. And even we do the children from 5 years and above to do a peak flow, so that you can be able to do for the adults, we do the height and the weight and the age. And then for the children of the pediatrics, we do only the age and height. We have several spirometry machines. So those are some of them. We are, the one that we are using in our hospital is Vitalograph spirometer system, which give us the overhaul of the lung function of the patients. So what is the spirometry machines? They are medical devices used to perform breathing tests on patients with respiratory symptoms, are used to diagnose, to assess severity and monitor the progression of a variety of respiratory diseases. Spirometry is a simple test used to help diagnose and monitor certain lung conditions by measuring how much air you can breathe out in one forced breath. So include on other lung diseases like interstitial lung diseases, like the fibrosis, anybody who have the COPD. It is carried out using a device called a spirometer, which is a small machine attached to a cable and a mouthpiece. So uses of spirometry is to diagnose asthma and chronic obstructive pulmonary disease and other conditions that affect breathing. Spirometer may be used periodically to monitor your lung condition and check whether a treatment for chronic lung condition is helping you breathe better. Spirometry measures 2 key factors: expiratory force vital capacity, FVC, and forced expiratory volume in 1 second. Spirometry can also determine your lung capacity. It measures changes over time that occur as a result of chronic lung diseases, identify early changes in your lung function, and in some cases, help guide treatment. Detect narrowing of the airways. It can decide how likely it is that inhaled medication may help in the symptoms. It can show whether exposure to certain substances has altered your lung function and estimate your risk of respiratory complications before undergoing surgery, especially those who are going surgery of the surgery for the lungs, those who have empyema, those who have lobectomy, all those have to go through the spirometry to check how the lungs are before they go to surgery. It's a key. So that is how a lung function is done for those who are in the counties and other places. So you can get them at the level 5 and the level 6 hospitals, and we can perform spirometry. So we have another devices which include others: fractional exhaled nitrous oxide. It is an invasive marker of inflammation in asthmatic patients. FeNO can be used to monitor airway inflammation but individual responses make tailored intervention based on phenol difficulty. Phenol devices are a novel medical technology used to aid in the diagnosis of asthma. Phenol devices measure fractional exhaled nitrous oxide in the blood of patients. Nitric oxide is a biomarker for asthma, which provides an indication of the level of inflammation in the lungs. So phenol test or exhaled nitric oxide test is done to patients with allergic or eosinophilic asthma. It determines how much lung inflammation is present and how well inhaled steroids are suppressing this inflammation. In allergic or eosinophilic asthma, sometimes one may feel the breathing is fine, but when exhaled nitric oxide is measured, it may still be significantly elevated, and maybe the inflammation has not been taken care of. So this can determine the stepping up of the treatment by increase of ICS to suppress the inflammation. So we come to the types of inhalers used in asthma, which Dr. Njari talked about them, a few of them. So you have medicine used in asthma. Inhalers are anti-inflammatory or inhaled steroid medicine. We have bronchodilators or SABA or beta-2 agonist medicine, or both, which have a combination of LABA ICS. The preventers is anti-inflammatory inhalers and are medicine used in asthma to prevent asthma attacks and reduce swelling and mucus production in the airways. This anti-inflammatory medicine help people get better and asthma control. So when you come to relievers, the bronchodilators, which Dr. talked about, the SABA or the Ventolin, it's a reliever or a bronchodilator inhalers that are either short-acting or long-acting. They are used to ease asthma symptoms such as wheezing, shortness of breath, and coughing. Inhaled bronchodilators dilate or widen the airways, which helps relieve asthma symptoms much faster than the oral medication, which Dr. Njari talked about, the prednisone, which he used to buy it in the counter as a prednisone. So the types of inhalers are small and had devices that deliver a puff of medicine into the airways. This is a common inhaler, an MDI, which is very common to other institutions that people need to know and learn on how to demonstrate to the client so that he can get the best benefit of the medication. There are three basic types. There are meter dose inhalers. There's the MDIs, the dry powder inhalers, the DPIs, and soft mist inhalers, the SMAIs. So note, while the inhalers use the same general principle, never assume that they all work the same way. For instance, while one is supposed to shake an MDI before using it, we should never shake a DPI or a dry powder inhaler. Each device needs to be cleaned differently and has a different way of tracking when it is empty. Always follow the instruction for the specific device. So these are some of the devices that we have in the market and also in our hospital for those who are in KNH. And let me tell everybody that spacers are not only for children alone. Let's put that in memory and mind that spacers are not for children alone. You have different categories of people who can use an inhaler, a spacer, especially the geriatrics, the old people, the people who have a poor respiratory effort, the special group, like the disability, like the cerebral palsy, the people with Down syndrome, guys with autism. What can you do to have the benefit? Because asthma, it goes across the board. Asthma, they're across the board. So the spacers are not only for children. They can be given for adults and for easy way of inhaling and also to get the benefit of the medication. And especially the elder, if you have a poor respirator or those who have an oxygen, may you use a spacer to help this patient to be able to get treatment and get the benefits so that they can be able to go home. These are several of the medications that we have in the market and also in the hospital. So we have this one is a hard inhaler. We have an MDI, we have a discus, and you have an MDI. So those are among of those things that we have in the market and in management of asthma and also COPD, and maybe other lung conditions. We have the tambohela, we have the how it is, and and how it is put on the cover. So for one to be helped, to be assisted. So we need to train our health workers and also to train our patients so that when they come, they can get the best treatment and best benefit when you're handling them in terms of the inhaler technique. We need to do a demonstration and do a return demonstration so that the patient can be able to understand on how to take the device. For those who take mask, you have to clean up the face with water and soap so that those who are using an inhaled corticosteroid, like children who are taking the budesonide, you can clean the face to prevent the absorption of the corticosteroid. And even for the geriatrics or the special group, if they are using an inhaler with a spacer, clean up the face to avoid the absorption of VCS in the skin. You clean it and then you condense so that it doesn't become the skin writer. For those who use with the mouthpiece, you have to rinse the mouth with water. And then you spit it up, you gargle it, and then you take some other water so that you can clean up the system, because those deposits of the powder can bring an issue like dysphonia. It can bring like GERD and candidiasis and all the rest. So you need to rinse your mouth when you are using a mouthpiece. And that is it. I think I've come to the end. I'm through, Dr. Atina.
Moderator, Dr. Atina.
Thank you. That was very quick and very good. I'm sure people have taken note. Kagima is passionate about gadgets. You could hear. She's also passionate about oxygen therapy, and many other things. I think now the floor is open since Mr. Moya is not there. We'll take questions. We have plenty of time. Some of them are in the chat box. I've tackled some of them. A lot of attendees are worried about CPD points. They have never got the token. I think the KNH research will answer that. But to start off, Dr. Nyale, there was a question about diet. I think that's probably something which falls square in what we are tackling today. Is it true that goat milk, maybe camel milk or other special kinds of milk are useful in asthma? You could start off with that one. Is there, and if you broaden, is there something patients want to, they usually ask this, what should I avoid in my food? Is this something I'm eating? So please, maybe you could tackle that aspect of asthma management, the diet aspect.
Now, asthma is a very personalized disease. People are allergic to different things. So not all people are allergic to the same things. So I know there has been the talk that goat milk is very close to human milk and that it has less allergens compared to cow milk. While that might be true, not all people react to the same things. So you have to note that it doesn't work for everybody. So if you find that you're allergic to cow milk, yes, you should change it. If you find you're allergic to tomato, yes, you should avoid it. If you find you're allergic to peanuts, then you need to avoid them. That's what we call environmental control of your allergens. So the diet is not a one fit all. And there's no diet that lowers inflammation or lowers asthma. There's even people who talk about the honey from Baringo, the one that is made by the small bees, that's a bit bitter. Well, it soothes your throat, but it's not going to treat the inflammation of the whole airway. So diet, we say all asthmatics should have balanced diet. They should also have a diary that looks at what they are allergic to. Once you know what you're allergic to, please try and avoid it. If you suspect some things and you're not sure, then you can have allergy tests, both for food allergens and for inhaled allergens. And if you are found to be allergic to those things, then you can avoid them. So that's what we say about diet and asthma. It's not a one fit all. Another question?
About immune therapy for asthma?
Now, immune therapy is something that has been looked at, but you see, it's not just immune therapy here. It has to be gene therapy. That looks promising in paper. In reality, it's not yet prime time. Gene therapy is what probably can change the genetic predisposition of people to asthma. Immune therapy on its own will only work for a short time because you are working towards the tail end of the reaction. Remember, the reaction is that you've got a person predisposed and an allergen. Then the two have to come together for the person to present with asthma. Now, immune therapy will work in reducing inflammation after the first event has occurred. So it's going to be less effective. It will be just as good as using inhalers on the long term. But it is a welcome thing because that's an extra bullet in the armamentarium of the doctors and the clinicians treating asthma patients. Gene therapy, on the other hand, promises to be much better because it will reduce the genetic predisposition of the asthmatic patient to have this airway overactivity. So that's much more promising, but it's not prime time. I don't know if
Thank you. I think you've answered. There's a question about asthma and bronchitis. What's the difference? I think those are two different entities. And I think this arises from the laziness of practitioners and clinicians. You want to tell the patient, you don't have the courage to tell the patient they have asthma because of stigma, which was not mentioned. So people have tell patients you have bronchitis, you do not have asthma. So, which I think is wrong. If the patient has asthma, tell them they have asthma. Maybe the nearest form of asthma, bronchitis, which maybe makes sense, is allergic bronchitis, but again, should call it asthma. So that's a question there, but I think there is a request here for stepwise management. I know you are not dealing with management, but perhaps you could use this chance to say one or two things about that. What is stepwise management of asthma?
Okay.
As of 2023.
Stepwise management of asthma is what is recommended by the GINA guidelines, so that's the international classification. And it's also there in our national guidelines launched last year. What basically it says is that people have different severities of asthma, and we call those severities, we put them in different steps of disease. And for each different step, we make a recommendation on the kind of medication they should have. Such that what it says is that people who have mild asthma should get less disease than those who have severe asthma that should get more disease. The steps are basically 5, okay, which run from step 1 to step 5 in that nature. We don't use any more mild, moderate, and severe, okay? So if you wanted to fit mild, moderate, and severe, you'd say step 1 is mild that comes occasional, mild intermittent, okay? Then step 2 would be mild continuous, most of the days having asthmatic symptoms. Now, for step 1, we recommend that they should get either a continuous steroid inhaler alone, low dose, or have a combined short-acting beta agonist with a steroid, so that this they can use anytime they use the short-acting agent like salbutamol, they also get a pulse of a steroid. That's for the step 1. Step 2, they have more symptoms, and they have symptoms more than 4 times daytime symptoms or 2 times at night in a week. And these ones, basically you want a more continuous medication. And usually we recommend low dose inhaled corticosteroid. Low dose, because we want minimal, okay? Then you've got step 3, those are a bit milder. They have symptoms that are a bit more than just mild symptoms, and they require probably a combination of a steroid and a bronchodilator, either a long-acting bronchodilator for control. So that goes into step 3. Now, step 3 on the higher end goes up to step 4, and in step 4, basically you're using higher doses of the same medication, and sometimes you might have a combination of 1 or 2 inhalers, okay? Basically adding a long-acting muscarinic agent as well. Then step 5, basically those are very severe asthmatics that they require not only health medication, sometimes they might require biologics or even steroids. And we usually recommend by the time they get there, probably refer them to Kenyatta or to a specialist who knows what's happening and can check other driving factors that make this asthma severe. So those are the 5 steps said loosely. And we recommend that for everybody, try and best put him in a good class or step and start with what is recommended. Then from there, you can always adjust medication. And you can adjust medication every week if you are seeing them, as long as you don't control. But you can only reduce it if they are controlled after every 3 months.
Thank you. I've lost my question chat. So I saw a hand which was up. Please put it on the chat. I don't know if Dr. Nyalo, you can see any more questions. I don't seem to have.
I can see a question. Somebody is asking, from what age do we say it's asthma? And for this, we start from 1 year and above. It's very hard for you to define asthma in less than 1 year. So usually 1 year and above, you're able to get a diagnosis of asthma from the pediatricians. There's also Yescot in asthma treatment. Well, Yescot is a steroid treatment. Yeah. Now, steroid treatments, especially oral, we use them a short course when people have acute worsening. But we also use them in severe asthma when we want to control severe asthma. So they're not your usual controller medication. They are really add-on for what we call severe asthma. And we don't use them for a long time, because if we use Yescot or other steroids, these are high doses. So you end up getting quite a lot of side effects from steroids. And if you refer to Dr. Google, the list might scare you. So we try and put it to a minimum. Then Philip Mwema asked, Doc, kindly tell us about status asthmaticus and care. Status asthmaticus is when somebody has a severe life-threatening asthma attack that's not aborting and it is continuing for a long time and it is life-threatening. For this kind of patients, basically you need urgent medical treatment in a good setup. And remember, usually the first thing you assess is, we always go in the order that the first thing is oxygen, because that's what kills patients. It's not how constricted the airways are. So the first thing is you check your oxygen. If the oxygen is low, please give them oxygen. Then the second thing, now you deal with the bronchodilation, whether you're going to nebulize them or you're going to give them multiple doses of pressurized metered dose puffs. And then the third one, you can look at what is precipitating that. Is it an infection? Or is it an allergen? Or is it that he missed his medication, and also try and address it. When asthma is very severe, then somebody can even end up in ICU. And basically that's a whole other subject that we can talk about on another day. But usually for people going to ICU because of asthma, it's a rarity. It's less than 2%. And you will see this in quite a lot of hospitals. Most people come there with shortness of breath the moment they nebulize. Most of them don't end up even getting admitted. Then anonymous attendee asks, for children less than 2 years, can you make a diagnosis of asthma when they are wheezing? Or do you wait for them to get to 2 years and above? Well, we've said 1 year, but the confident one is after 2 years. Usually for the ones under over 1 year, we call them persistent wheezers. So that persistent wheezers, and if they have a family history and other things that we can add on, then we can make the asthma diagnosis. Below that age, it's usually very difficult, yeah? And there's a lot of confounders. And you can't be able to test them objectively for you to say that there is airway inflammation and this is asthma. So that's usually the difficulty. So usually we say confidence after 2 years, but you can't be able to infer when you're 1 year and above. Do you have Mometerol? When to give Mometerol to salbutamol inhaler and how long to continue after relief? I'm not sure what Mometerol is, but he was, I think, was trying to say Salmeterol. Okay, this is a steroid. Okay, because we don't use mometasone, it is actually salmeterol, that's equivalent. Usually it depends on what stage of asthma you are. And we add it usually from step 2 and above, but because it's not a reliever per se, it's a controller if you're using salmeterol. So usually these controllers is you have to use them on a daily basis, morning and evening, or once a day, until the doctor downsteps them at 3-month interval. Is allergic asthma, is it also genetic? Yes, most of the allergic asthma is actually genetic. And they usually come with the whole constellation of all the allergic manifestation, including eczema, allergic conjunctivitis. So most of the allergic asthma has a genetic basis, and most of it comes with all the other constellation of allergic diseases. When do we need to prescribe antibiotics in asthma? Most of the time is 0. We don't need antibiotics in asthmatic patients unless you can prove that what has precipitated the status asthmaticus is basically a bacterial infection. Remember, most of the studies show that most of the triggers are either allergens or viral infections as opposed to bacterial infections. So I hope I've answered you, Philip Mwema. Austin Okoth says, ask doc to give a summary of the asthma stepwise management. That one done. Then Dr. Kilosh Kumar Devluk asks, what is the role of allergic lab test and allergic treatment? Now, we said one way of controlling asthma is lowering your allergens. And you can only lower allergens that you know. If you don't know the allergens, then you can't lower your allergic exposure. So the trouble we have with allergic tests, and even we got this trouble when we were looking at the antigens that we needed, is that a lot of the African antigens are not included in this skin prick test and even in the food allergy testing. So we've got to make a conscious effort now to include the African cockroach, to include African weeds, Napier grass, and the rest. Now, it's not easy because once you want it included, you have to pay quite a lot of money. So we need tests that are specific for our region, for this allergic testing to make sense. Because if you are tested against a weed that appears in winter in Europe, or in spring in Europe, how is it relevant to the patient in Kenya? So we know that, yes, allergy testing has a role. The role currently is limited. It's not very big because the repertory of the allergy or the spectrum of the allergens in the tests is limited for our setting. But once we've got a good representation of local allergies, that probably should include Kakamega peanuts and also include things like sukuma in there. There are people who react to these things, I'm serious, and the African cockroach. Then testing and laboratory testing of the allergens will be a very important thing. And at that time is, if you're going to treat allergy, there are various things that you can do. One, you can do desensitization. Desensitization means if you expose the immunity to slow increasing doses of that drug, then it should get to a point that the immunity understands that this is one thing that the body is good. So it's like the same way you introduce somebody to your dog in small exposure doses so that they don't overreact. But you have to be careful not to kill the patient, okay? The other thing is what most people practice is completely avoidance of that allergen. The other things that people can use, like using gels that cover the nose, mucus of the nose, so that in spring they can't inhale all those pollens. That's also another thing that we can consider in terms of allergic treatment. Dr. Tina, are you back with the questions?
Yeah, I'm looking at them. Thank you for answering a lot of them. I think a lot of them are to do with treatment, which you are not really tackling today. But I would like you to comment about diprofos. It's one of the questions there.
Okay.
Where does it fall in the stepwise management of asthma?
Now, diprofos is one of the things that has given us a nightmare in management of asthma. Dreyfus is a long-acting depot steroid. It's not that it doesn't work. It's that you are using a bomb to kill a louse. And it causes a lot of collateral damage. So when you give people Dreyfus, first of those, you lower their immunity, they become prone to getting infections. So you'll see infections will increase in these patients. Two, they're going to lose bone because it does cause osteoporosis. It also causes more irritation in the gut and increased acidity. It causes skin to thin and people have bruising. It causes the adrenal gland to fail when used for a long time. So Dreyfus is nowhere in our guidelines. So what we prefer are short-acting steroids that you have a hang on, and we usually say even in an acute attack when you need a steroid, we use it for 3 to a max of 5 days. So Dreyfus is not there and we don't recommend it. We know a lot of the people who are trained, we call them the pre-Yahoo generation, still give quite a heavy dose of Dreyfus, yeah? You know, by the way, by looking at your email, you can tell how old the person is, yeah? I was told if you are still having a Yahoo email, you cannot be under 40. If you are in Gmail, you can not be under 20. So it's something that you need to get used to. So I know the older generation used to give those high doses of steroids, but they are not, the depot steroids are not anywhere in our treatment.
Thank you. And so that then tells us the follow-up question on inhaled steroids. So if you want to use steroids in asthma, they have to be inhaled for the reasons he explained earlier. There are many doses, micrograms, they go to the lungs and they don't go anywhere else. So very little absorption into the systemic absorption. So the side effects are largely done away with. So you will need steroids to control your asthma, but they are going to be inhaled. So inhaled corticosteroids, not oral or injection. I think we probably tackled most of the questions. There's a comment from Dr. I think Okot from sports medicine. I think that will be a discussion for another day, asthma and sports. But maybe it was just a comment. The short answer is that people can be sports people, they can be world beaters. A lot of our marathon heroes have asthma, and that has not prevented them from participating and winning medals. I don't know if there's any other burning question here.
Maybe what we should say, maybe what we should also say, Dr. Tina, yes, is that most of the asthma medications are on the ban list for the World Athletics body. That's since the Beijing Olympics, when over half of the competitors who won gold medals were actually on asthma medication. And the question became, did asthma medication enhance performance? So when asthma is well treated and some of this asthma medication, probably it might enhance performance, yeah? And well, you might not be an athlete, but it can enhance your performance anywhere where you are.
Yes, and I think there's also, I hear it from patients, steroids, when they hear the word steroid, I think those are not probably the steroids we are talking about. There are those steroids which build muscle, for example, used by the sprinters. That's a different category of steroids, not what we use here in asthma. So that whichever way you need to be, you stay safe, use inhaled ICS corticosteroids rather than those others. I think that is it then for us. The rest of the details are about management, nebulization, what and what. I think my take from this is that we will need to arrange another webinar on management of asthma. This was really misconception. This was more like in an awareness sort of session rather than a specific treatment session. But I think we can arrange another session on asthma, COPD, and the others, and the other obstructive airway diseases. I think I would like to end this year. We are 15 minutes. We have done well. I would want to thank our presenter, Kagima. Maybe you'll give us a final word, and Dr. Nyale as well before we say goodbye to World Asthma Day 2023. Kagima, are you still there?
I'm still there, Dr. Ali.
Yes.
It is a good interactive session. And for those that we need to, talking about the nebulization, we need to think about how well do we do nebulization for whoever had asked the question. How do we prepare our medication? How do you propose the patient? How do we give it? It's a whole session. That one we shall do it in another day. And also for those who have asked about the inhaler technique, we shall do that session after Dr. Nyale does the management, and then we can do the other devices. Then you can be able to do it, maybe. Okay. But thank you very much for being here. And thank you for everyone who joined in. May God bless you.
Okay. Nyale.
Yeah, I don't know what to say, but I think it is overwhelming. It's long since I saw 871 people logging onto our webinar. And this is really, really encouraging. And thanks to all the guys who logged in from all the counties. Today it was awareness. It's actually care, asthma care for all. So we're doing awareness, and that's why we avoided all the jargon of management. But as Dr. Yatina said, it looks like people want to hear more about asthma management. So we shall plan a series, basically, geared towards both the doctors, clinicians, and nurses on not just treatment, but tidbits of how you treat chronic stable asthma, how you treat acute severe asthmatic attack, how you make a personalized asthma plan, what are the goals in therapy of asthma, and if you're interested in asthma research, how do you do it? Because that's something else that we really lack. And even when we do some of these researches in Kenyatta, I think we should cascade down to the counties so that people in the counties can actually participate in these studies and have local data, like what we were showing today, that we have data from Baringo saying asthmatics in Baringo have this and that and that. And we have data from Garissa saying that when you see an asthmatic in Garissa, these are the things you think about. If we have one from Narok, it says these are the allergens most likely from Narok, and this is what you're supposed to address. So there's a wide scope. It's a wide disease. The good part is that the ministry has taken a good lead. It has included it as one of the priority diseases in the National TB and Lung Diseases Program. Remember, it's not called National TB and Leprosy anymore. It's called National TB and Other Lung Diseases Program, which has basically taken up asthma, and I think it's running with it. And we are very happy and hopeful that this space now has been taken up and we'll start seeing quite a lot of things. Thank you very much. And this is very encouraging, and God bless you all. Thank you.
Thank you. I also want to say thanks to our attendees. We are happy that you joined in. We also saw an impressive turnout when we were celebrating TB the other day. We promise we'll do another series on both diseases. And if you are able to reach us, we make suggestions. And Dr. Kinuthia from research mentioned there, he answered the question on CPD. Please send your email address to them. Then your CPD point will be loaded direct to the portal. So that's how they are doing it. So please send your email. If you check in the chat box, he has given the answer there. So thank you very much and have a good night. You may now leave at your own leisure.
Thank you very much and good night all.
Thank you as well from the KNH research team.
Thank you, everyone.
We can organize a series on this, as you have said. We're looking forward to more. Thank you and have a good evening.
Thank you.